All right, it is exactly 12 o'clock p.m., so let's go ahead and get started. Good afternoon, everyone, and Happy New Year. Welcome to the first Department of Medicine Grand Rounds 2022. My name is Brian Abe, and I'm one of the chief residents here. I have the pleasure of turning over the stage to Dr. Rotanya Carr, Cyrus E. Rubin Endowed Chair and Division Head of Gastroenterology here at the University of Washington, who will introduce our speaker for today. Dr. Carr.
Thanks, Dr. Abe. I appreciate this. Since you're going to be formal with me, I'll call you Dr. Abe. I'm really excited today to really have this honor and distinct privilege of introducing to all of you really one of my friends, longtime colleagues, Dr. Andrew T. Chan. I've known Andy since I was a resident at the Massachusetts General Hospital, and he was one of my chief residents. Admired him then as I do now, and I hope that all of you will get to see just why momentarily. We invited Dr. Chan here today as our Dr. Wade Vollweiler, visiting professor. As many of you may know, Dr. Vollweiler started our division in 1949. He, along with Dr. Cyrus E. Rubin, were the only two members of our faculty, and Dr. Vollweiler led us for 31 years. So it was his vision that created who we are today. Dr. Chan was invited in his honor. Dr. Chan is a gastroenterologist, the Daniel K. Podolsky Professor of Medicine at the Harvard Medical School, Professor of Immunology and Infectious Diseases at Harvard T.H. Chan School of Public Health, Chief of the Clinical and Translational Epidemiology Unit at the Massachusetts General Hospital, and the Director of Epidemiology at the MGH Cancer Center. Dr. Chan is internationally known and recognized for his work in cancer prevention and as a population scientist. He works in cancer prevention as well as interception and has led several prominent studies examining the role of aspirin diet and the gut microbiome on cancer health. He is supported as an outstanding investigator of the National Cancer Institute, team leader for the Stand Up to Cancer Gastric Cancer Interception Team, and by numerous grants from the NIDDK, National Institute on Aging, as well as the NCI. He's an elected member of the American Society for Clinical Investigation and the Association of American Physicians. He has published well over 500 papers in leading journals, including our own Gastro and Gut, as well as in the New England Journal of Medicine, JAMA, Lancet, Science, and Nature Medicine. He is a section editor for gastroenterology and serves on the editorial board of JNCI, Cancer Prevention Research, Cancer Epidemiology, Biomarkers, and Prevention. He's the clinical research counselor for the AGA and also chair of the molecular epidemiology group of the American Association for Cancer Research. He has earned numerous honors in addition to those I mentioned above over his lifetime. And I'd like to make special note that he was even a finalist as a Rhodes Scholar, and over the past several years was cited as one of the top 1% of investigators who have been cited. Clinically, he cares for our most vulnerable patients, those who are high risk for cancer, including those with genetic cancer syndromes. And he has many ties to our own community at the UW, many collaborations with investigators at the Fred Hutch, as well as our main campus at UW. Without further ado, I'll introduce you to my friend, colleague, and really one of my inspirations, Dr. Chan, who will talk to us about molecular cancer prevention with aspirin.
Thank you very much, Rotanya. It's great to be here and really an honor to be the Wade Vollweiler professor this year and to be a part, to be able to be a part of this distinguished lecture series. It's also been terrific to have the opportunity to be able to share the last couple of days with just an amazing Department of Medicine and Gastroenterology division. I've had a lot of wonderful colleagues and friends over the years at the UW, and so it's been a terrific visit, and it's been great to see and be able to experience some of the great things that are going on at this institution. So over the next 45 minutes or so, I would like to share with you an area of research that has been something that I've been interested in for all my career. And a lot of this really started even as a resident when I was in the primary care program at MGH. I knew as a person who trained in that program how important it is to consider disease prevention in our interaction with patients. And I think one of the fundamental issues that patients often want to discuss with their physicians is, what is it that I can do to prevent developing cancer? And although I didn't continue in primary care, I did train in gastroenterology. I was really interested in GI because of the idea that GI is on the front lines of cancer prevention with our role in colonoscopy. But I think going back to my initial roots in primary care, I've always also come to appreciate the importance also of thinking beyond screening and beyond colonoscopy for prevention of colon cancer. So these are some of my disclosures. So just to take a step back, I think we all understand that among cancers, we're fortunate that colorectal cancer does have a proven modality for prevention, that is screening. Of course, there's still quite a lot of work to be done in terms of understanding what the best screening is for a population. And I think it's still important to consider screening to be a cornerstone for what we offer our patients. But we were interested in understanding what the impact of colonoscopy screening specifically was on colorectal cancer, because quite clearly, even back in 2013, when there was a tremendous amount of colonoscopy screening happening, it wasn't altogether clear that there was strong evidence supporting that colonoscopy was associated with a lower incidence of colorectal cancer. So we conducted this study back in 2013, leveraging data from the Nurses' Health Study and Health Professionals Follow-Up Study, which I'll go into a little more detail in the future. But suffice it to say, a postdoc in my group, Reiko Nishihara, led this study and demonstrated that over long-term follow-up, the men and women who underwent colonoscopy screening had about a 30 to 40% reduction in the risk of developing colorectal cancer. But there was a limitation in sort of the effectiveness of colonoscopy, with the strongest risk reduction seen for distal colorectal cancer of about 75%, but comparatively weaker reduction in risk of proximal cancer of about 25%. So although colonoscopy appears effective, there are limitations in its ability to prevent cancer. So this has subsequently led us to think about other types of modalities for prevention. And in particular, I've been interested in the idea that cancer could potentially be prevented through repurposing pharmacological agents that are already widely used. In particular, I became interested in the use of aspirin. And this was prompted by a really strong body of epidemiological literature. Over 100 case control and cohort studies have been published that have shown that people who take aspirin in general have a lower incidence of colorectal cancer. And these have been across different populations and different study designs, really demonstrating quite clearly a consistent association. In addition, there have now been 5 different randomized control trials of aspirin for the prevention of colorectal adenoma in patients that had a prior history of adenoma or polyp. So this, I think, provided very clear, compelling evidence of causality that aspirin was something that could reduce colon cancer. In addition, there was a publication in 2010, and then a series of additional publications 2 years later, that showed that if you looked at data from the very large number of clinical trials conducted of aspirin for the prevention of cardiovascular disease, if you looked at those trial participants and those data were linked eventually to cancer outcome data, individuals originally randomized to aspirin had a lower incidence of developing colorectal cancer or dying from colorectal cancer. In addition, there was also results that emerged from a large randomized trial of aspirin in patients with Lynch syndrome, which is a principal hereditary colorectal cancer syndrome. In patients with Lynch who have a genetic mutation, they have about a 70% lifetime risk of developing colorectal cancer. And in Lynch patients, a dose of 600 milligrams of aspirin per day reduced the risk of developing a colorectal cancer after 10 years of follow-up. And finally, there was long-term results that were published from the Women's Health Study, which was the largest randomized trial of aspirin for the prevention of cardiovascular disease and cancer that's ever been presented in a primary care setting. And in this, in a primary prevention setting. And in this study, women were randomized to 100 milligrams of aspirin every other day. And over a 10-year period, there was no initial reduction in colorectal cancer incidence, but after 10 years of follow-up, there was about a 30% reduction in risk of developing colorectal cancer among those women that were randomized to aspirin. So there was quite a large body of epidemiological data and randomized clinical trial data of adenomas and also colorectal cancer that suggested that aspirin could really be a promising agent for prevention. Now, I've been fortunate to be able to complement this evidence base with studies that we've conducted in two large epidemiological cohorts that are based at the Harvard School of Public Health and the Harvard Medical School. The first is the Nurses' Health Study, which is comprised of 121,700 female registered nurses that were enrolled across the United States since 1976. In addition, in 1986, a parallel cohort of health professionals were enrolled of 51,000 men. Since 1980 in the women and 1986 in men, these cohorts have been followed carefully for their lifestyle factors as well as their medication use, including very detailed assessments of whether they take aspirin over the last 2-year period. In addition, over follow-up, the men and women have reported if they've been diagnosed with colorectal cancer, and if so, they then have their cancers adjudicated and confirmed with medical record review. They've also reported if they've had a colonoscopy and if they've been diagnosed with a polyp. If they've been diagnosed with a polyp, their medical records have been reviewed, and if the polyp is an adenoma, that's also been confirmed. This has been a really enormous source of valuable data because the men and women in these studies have been so adherent to the protocol and have participated with follow-up rates over 90%. And have really been exceedingly generous in the provision of both their personal health information, but also over the years, their provision of biospecimens, which have provided us an opportunity to understand the molecular basis of a lot of the lifestyle factors and their association with cancer. Over the last 30 or so years, every 2 years, again, the men and women have updated their information on aspirin, which is very important because obviously aspirin use at any one given moment in time may change. And as you can imagine, over a life course, whether people use or not use aspirin has changed quite a bit, and that's important data to capture, which I will illustrate to you in a study we conducted very recently looking at the impact of aging and aspirin on cancer risk. So in one of the earliest studies we conducted, we examined the basic question, does aspirin use actually associate with a lower risk of incident colorectal cancer in these large population-based cohorts? We did find that regular users of aspirin had about a 25% reduction in risk of colorectal cancer, but what was potentially the most important finding was that this association was dependent on duration of use. If women used aspirin for less than 5 years or even less than 10 years, the reduction in risk of colorectal cancer was not really very evident. But if you looked at women who used aspirin for at least 10 years, you started to see reductions in risk of about 25 to 30%, which was very consistent with data from the randomized trials of adenoma prevention, which also showed a reduction in risk of adenoma of about 25%. I think this is consistent with our understanding of the biology of colorectal adenoma. We think most polyps and adenomas probably have a dwell time of 5 to 10 years before an adenoma can become a cancer. So it's not surprising that a short-term study of adenoma occurrence could see a decrease in adenoma risk in the short term, but a decrease in risk of colon cancer would require at least 10 years of follow-up. These data, I think, also led to the understanding that future studies of colorectal cancer, including studies from clinical trials like the Women's Health Study, would need to look at long-term outcome and long-term follow-up. So as I mentioned before, the Women's Health Study did not see a reduction in risk of invasive colorectal cancer in the first 10 years of follow-up, but after they followed the participants for at least 10 years, they did see a reduction in risk. So I think this provided some additional support for the need for long-term follow-up for any clinical trials or observational studies of aspirin and colon cancer risk. Of course, there is a downside to aspirin use. As a gastroenterologist, I certainly understand that we can see toxicity, in particular GI bleeding. And this is something that we've also observed in the Nurses Health Study with long-term use of aspirin. Ed Wong, who was a GI fellow working with me at the time, showed quite convincingly that aspirin was associated with a higher risk of GI bleeding, and that risk was very much dose dependent, with a greater number of standard tablets of aspirin used per week being associated with the highest risk of bleeding, or about twofold higher risk of bleeding for those people that used at least 14 tablets of aspirin per week. So given this toxicity, there really is a need to think about aspirin for cancer prevention, but think about it within the standpoint of needing to be specific about who we actually consider using aspirin on. In particular, to be able to balance the risks of taking aspirin against the potential benefit. And in 2017, a distinguished panel of cancer researchers and policymakers came together through something called the Lancet Oncology Commission to come up with cancer research priorities for the US. And a conclusion of that meeting for prevention was the statement that perhaps the most promising precision-based approach to cancer prevention in the near future involves molecular selection for repurposed low-dose aspirin. And it's this molecular selection for precision prevention that I want to focus on today. So what do we mean by molecular prevention? Well, among potential mechanisms by which aspirin works, based on experimental models, it appears the most promising mechanism by which aspirin may operate as an anti-cancer agent is its effect on prostaglandins. We know that aspirin inhibits the conversion of arachidonic acid to prostaglandins via blockade of what's known as the cyclooxygenase 1 and 2 enzyme pathways. Prostaglandins are known to be pro-carcinogenic in that they encourage different pathways that are known to promote cancer. So at least a major mechanism by which aspirin may prevent cancer is its ability to interrupt the synthesis of prostaglandins through blockade of the cyclooxygenase enzymes. But that was really data that emerged primarily from animal studies, and it wasn't entirely clear whether the association of aspirin with cancer risk was actually mediated by a prostaglandin-dependent mechanism. So this led us to ask the question, in a human population, does aspirin relate to lower risk of colorectal cancer according to its effect on COX-2 or PTGS2 pathway? So PTGS2 is just another nomenclature for COX-2. And in this study we conducted in the Nurses Health Study back in 2007, we found that individuals who were regular users of aspirin had, again, about a 25% reduction in risk of colorectal cancer. But what we did is we also took the colorectal cancer tissue, the participants that were diagnosed with cancer in the cohort, and then performed immunohistochemical staining of the tissue for the PTGS2 or COX-2 enzyme, and classified tumors as to whether they were COX-2 positive or COX-2 negative. And what we found is that regular aspirin users had about a 30 to 40% reduction in the risk of developing a COX-2 positive tumor. In contrast, there actually was no reduction in the risk of a COX-2 negative tumor. So fortunately, most colorectal cancers are COX-2 positive, which explains why there seems to be an overall benefit on cancer. But I think this provided some of the first human data to suggest that the effect of aspirin on cancer, colorectal cancer in humans, was mediated by a cyclooxygenase 2 or PTGS2 related pathway. Of course, when we think about molecular prevention and molecular selection, this raises the possibility that COX-2 or COX-2 expression or PTGS2 could be a biomarker of response. But we also wanted to explore other potential biomarkers of response, including other enzyme pathways that were relevant to prostaglandin synthesis. So we specifically wanted to focus on another enzyme pathway, which was the 15-prostaglandin dehydrogenase pathway. And this enzyme system is important because of its potential role in colorectal cancer that's been substantiated by other evidence and other experimental models. In particular, 15-prostaglandin dehydrogenase is an enzyme which is ubiquitously downregulated in colorectal cancer. And in large part, I view it as being sort of the antagonist to what COX-2 does. So COX-2 is the enzyme that breaks down and inhibits prostaglandins, synthesizes prostaglandins. And so aspirin operates by blocking COX-2 and therefore blocks the production of prostaglandins. On the other hand, 15-PDDH is a principal enzyme that actually catabolizes or breaks down prostaglandins. And so high levels of this enzyme would be expected to be important in making sure that prostaglandins are actually appropriately catabolized. And you can imagine that a deficiency in 15-prostaglandin dehydrogenase could lead to high levels of prostaglandins. So the way I like to think about it is that COX-2 is sort of the accelerator on the system. You push on COX-2, you get more prostaglandins, and 15-PDDH is the brake on the system. If you have more 15-PDDH, you actually reduce the amount of prostaglandins. So it's been found in colorectal cancer tissue from humans that 15-PDDH is actually ubiquitously downregulated. You also have evidence from animal models that if you knock out this enzyme, you actually see an increase in prostaglandins in the colon, as you would expect. You also see the promotion of colon tumors in animal models. And also the colon tumors in those animals are resistant to the anti-tumor effects of a COX-2 inhibitor like celecoxib. In addition, there was at the time pilot data in a human study of celecoxib, or a COX-2 selective inhibitor, in adenoma prevention. The adenoma prevention with celecoxib study looked at celecoxib and found that individuals overall randomized to celecoxib had a lower risk of developing a colorectal adenoma, which is ostensibly because it blocks the synthesis of prostaglandins. However, in that particular trial, if you assayed their levels of prostaglandin transcripts in the normal colon, those individuals that had low levels of prostaglandins in their colon had actual resistance to the anti-adenoma effect of celecoxib. So we wanted to ask the question, could also assessing the level of the prostaglandin metabolite in normal colon mucosa also be used as a biomarker? So we extracted RNA from the normal colon tissue that was surrounding the colorectal cancer tissue in colorectal cancer tumor resections. And then in collaboration with Sandy Markowitz at the Case Western Reserve University, used an RT-PCR to quantitate the levels of 15-prostaglandin dehydrogenase mRNA in those colons. And we did find a very interesting result. So in this study, which was led by Steve Fink and Dr. Markowitz's group, we assessed the effect of aspirin on cancer risk according to the expression of 15-prostaglandin dehydrogenase in normal colon. And we found, again, overall regular aspirin use was associated with about a 25% reduction in risk of colon cancer compared to those who didn't use aspirin. But if you actually stratify the cohort according to the level of colonic expression of 15-PDH, you found that the association of regular aspirin use with lower cancer risk was markedly stronger, about 50% risk reduction in those individuals that had intact levels of 15-prostaglandin dehydrogenase in their normal colon. In contrast, those individuals that had low levels of 15-prostaglandin dehydrogenase in their colon had no appreciable reduction in their risk of colorectal cancer. This suggested the possibility that 15-prostaglandin dehydrogenase could be an enzyme pathway and a molecule that needed to be able to be present to cooperate with the effect of aspirin in order to have the anti-cancer effects of aspirin be fully realized. But going more deeply again into molecular selection and molecular pathways, we wanted to ask the question, we've got some candidate biomarkers. We have, for example, a biomarker in COX-2 and a biomarker in 15-PDDH. Is there also potentially another biomarker we can use that may be even easier to assess? And in particular, is there, for example, a non-invasive biomarker, for example, a urinary biomarker that could be used as a way to risk stratify? And that's where we became interested in urine metabolites or prostaglandin metabolites, which can be collected in urine and assessed for its potential as a biomarker of prostaglandin tone. So how is it that PGEM became a possible biomarker? Well, one of the earliest studies that was led by Wei Zheng's group at Vanderbilt University did this very intriguing study where he looked at women enrolled in the Shanghai Women's Health Study prospectively over many years. And what he found was that a baseline urine assessment of prostaglandin metabolites predicted the eventual occurrence of colorectal cancer over follow-up. He found that actually the women in the highest quartile of prostaglandin metabolites in their urine had a risk of developing an incident colorectal cancer over follow-up of about 5.6-fold. So this was actually very interesting to us as a potential biomarker for colorectal cancer, given this finding in the Shanghai Women's Health Study. We became interested also in knowing, well, is it just an association with cancer risk, or could this also be a potential association with risk of adenoma or adenomatous polyps, knowing that adenomatous polyps are the principal precursor lesion for the vast majority of colorectal cancer. So we conducted this study with the help of Navya Bezawada, who was a medical student at the time, as well as a postdoc in our group, Mingyang Song. And what they looked at was the association of urinary prostaglandins in women enrolled in the Nurses Health Study and the risk of developing an incident colorectal adenoma over follow-up. And they found that the women who had the highest quartile of urinary prostaglandins had about a 1.6-fold higher risk of developing an advanced adenoma compared to those women in the lowest quartile. And if you really looked at the data, it suggested that this was a potential biomarker for not just cancer risk, but also for adenoma risk. Also, what we found was that if we looked at the aspirin information in this cohort, we found that women who used aspirin had a reduced risk of adenoma if their baseline level of urinary prostaglandin was high, with a reduced risk of adenoma about 40%. But if their baseline level of prostaglandin metabolites were low, they didn't seem to benefit. So this suggested the possibility that those individuals that tend to be creating polyps or adenomatous polyps on a prostaglandin-dependent pathway with high levels of prostaglandin tone were the ones that would benefit the most from an agent that would block prostaglandin synthesis like aspirin. So this suggests the possibility that this could be a really important biomarker going forward. These data were also corroborated by data from other groups, including data from trials of aspirin in adenoma prevention. In particular, I mentioned that there have been 5 randomized trials of low doses of aspirin that have shown that people randomized to low doses of aspirin who had a prior adenoma or prior cancer have a 15 to 25% reduced risk of developing a recurrent adenoma. And in particular, I want to highlight the Aspirin study of 1,121 people because they also examined levels of urinary prostaglandins with their participants. In this study that they published, they found that urinary prostaglandin metabolites were lower among those who were randomized to aspirin post-intervention. In addition, there did seem to be a very big difference between low and standard doses of aspirin. Of course, the caveat with this study was that there was only an assessment of urinary prostaglandins post-treatment, so not before they received aspirin. And so it was really only able to kind of cross-sectionally look at this association, which suggests that maybe aspirin treatment could lower prostaglandin metabolites. In addition, what was intriguing was they also saw an interaction between prostaglandin metabolites and aspirin use. Those participants that had low levels of prostaglandin metabolites are the ones that look like they benefited from aspirin with a relative risk of recurrent adenoma of 0.62. In contrast, those individuals that had high levels of urinary prostaglandin did not seem to have a substantial reduction in risk of recurrent adenoma. So another study, in addition to ours, that suggested the possibility this could be a biomarker for cancer prevention. So this led us to launch this trial. And so we really wanted to do a trial where we could specifically look at the effect of aspirin on the levels of urinary prostaglandin, because really there weren't any data at the time to actually show that aspirin itself could reduce prostaglandin levels, only cross-sectional data. So at the MGH, we enrolled a cohort of individuals who underwent adenoma resection, and specifically enrolled 180 people and randomized them in a double-blind manner to placebo, 81 milligrams of aspirin, or 325 milligrams of aspirin for 8 to 12 weeks, with the primary outcome being change in urinary PGM. In addition, we were able to collect a variety of biospecimens at baseline and post-treatment to look at a lot of other potential cancer-related biomarkers and really explore those as potential risk stratifiers for chemoprevention. So this is the primary outcome results of the study, which we published back in 2020. And this was a paper led by David Drew, who was a postdoc at the time and is now a junior faculty member at MGH. And what we found was that indeed, individuals randomized to either 81 milligrams of aspirin or 325 milligrams of aspirin did have suppression of the urinary prostaglandins after only 2 months of aspirin treatment. And if you actually look at the relative reduction, we saw about a 30% reduction in levels of prostaglandin concentrations in people that were randomized to either 81 or 325. Looking at this data in another way, you can see on these waterfall plots, on the placebo arm, you sort of have an even balance of people who had either a slight increase or decrease in urinary prostaglandins, but those randomized to aspirin, clearly the vast majority of participants who had been randomized to aspirin actually had reductions in the prostaglandins, as you would anticipate. And if you look at the primary outcome, about 50% of people randomized to 325 and 81 milligrams, randomized to 81, had a reduction in urinary prostaglandin levels of at least 33%. And why is 33% important? Well, in the study that we did in the Nurses' Health Study, we found that suppression of prostaglandins by about 30% was what was associated with a substantially lower incidence of adenoma over time. This was also corroborated with thresholds that were selected from the study in the Federico paper, which looked at the adenoma prevention trial. And what we found there was that approximately 40% of people in the 325 milligram group and 25% of the group randomized to 81 milligrams of aspirin had a reduction in prostaglandin metabolites below 5.34. And this was a threshold where they started to see a benefit with respect to adenoma prevention. So this led us to propose this model for biomarker-based precision prevention. And this was a review that we published earlier last year to really consider a strategy in which we consider a precision prevention approach at the time of colorectal cancer screening. So you could imagine potentially if you have a colorectal cancer screening exam with a colonoscopy and or diagnosed with adenoma, you could use that as an opportunity to potentially measure someone's baseline prostaglandin metabolites. If they're high, they would be potentially a candidate for low-dose aspirin. And you could test them with treatment for a couple of months, as we did in our clinical trial, to see if they actually had a suppression in urinary prostaglandins that would be high enough to suggest an inhibition of future adenoma risk. If, however, there was no change in urinary prostaglandins, it could be that they needed to be treated longer, or they need to be treated with a higher dose, or maybe treated with a different prevention agent. So this potentially is a model that could be tested in the future in clinical trials to use prostaglandin metabolites as a risk stratifier for aspirin treatment down the road. So the question is now, can we actually exploit aspirin's mechanism of action for further informing strategies around personalized prevention? Well, prostaglandin metabolism is certainly a good proof of principle, but it's an imperfect biomarker. As we showed in our clinical trial, there's still upwards to 50% of the population that may not have sufficient suppression of urinary prostaglandins to the level that would reduce risk of adenoma. So can we think about other ways of actually molecularly stratifying people based on risk? And so are there potentially other mechanisms that we should explore? And I won't have time to go into this in detail, but in a review article that we published back in 2016, we summarized the epidemiological data and also data from our group examining other molecular pathways that seem to be promising in explaining the anti-cancer benefit of aspirin. That includes the direct effect of aspirin on beta-catenin pathways, which is one of the principal canonical pathways by which cancers develop. In addition, there could be effects of aspirin on platelet pathways, and platelets have received sort of reinvigorated interest as being potential mediators of cancer spread. And the anti-cancer effect or the anti-platelet effect of aspirin could be a reason for why cancers might be inhibited from spreading. In addition, there's been increasing interest in the association of aspirin with various immune pathways. And we know that immune pathways are really important in sort of immunosurveillance of early pre-cancerous changes and cancerous polyp progression. So it could be aspirin's effects on modulating anti-tumor immunity could be an important role for its anti-cancer effect. In addition, we've been increasingly interested in the role for the microbiome in mediating aspirin prevention. And earlier this morning, I had the privilege of presenting our work in the gut microbiome and diet on colorectal cancer. But I think we've also been, and I presented that to the Division of Gastroenterology, but I think I'd also like to suggest the possibility of the microbiome being an important player in cancer could also be mediating the effect of aspirin on prevention. And there's been increasing data that aspirin could play a role in specific microbial and metabolite pathways, including bile acid-related pathways that are known to actually promote the expression of PTGS2 or COX2. So some of these pathways related to arachidonic acid and prostaglandins could very much intersect with microbial pathways. And that's something that we hope to explore using some of the biospecimens we've collected in our clinical trial, Aspired, where we've collected stool specimens and also tissue samples in the participants randomized to aspirin. There's additional data to support this. This is a collaboration that we had with Wendy Garrett, who is a world leader in microbiome science at the Harvard School of Public Health. And she's been a pioneer in animal models of the microbiome. And what she's shown is that if you look at APC min mice, so one of the main models for which colon cancer is modeled in mice, what she actually showed that aspirin can potentially inhibit colon adenomas that are provoked by Fusobacterium nucleatum, which is a microbe that's been strongly linked to colorectal cancer. And if you treat the animals that have adenomas provoked by Fusobacterium, if you treat them with aspirin, there is a suppression in their adenoma count. In addition, in a human study, we actually found that individuals that used aspirin tended to have lower abundance of Fusobacterium in their adenomas compared to those who were not using aspirin. So providing some really tantalizing information that maybe intersects these really important emerging pathways for colorectal cancer progression. But I think things are not entirely simple, and I want to lay out the sort of changes that have come about with respect to aspirin and our thinking about aspirin that have resulted from newer data that have come out in the last couple of years. So as I think I mentioned, there has been a lot of substantial data supporting the use of aspirin for prevention. And in 2016, the U.S. Preventative Services Task Force actually came out with a recommendation that suggested that people between the ages of 50 to 59 consider using aspirin for prevention of not only cardiovascular disease, but also cancer. But the USPSTF recently revised their guidelines in October of 2020 to suggest that aspirin not be used for primary prevention, largely because of data that emerged from new clinical trials. In addition, they have concluded that maybe the evidence supporting low-dose aspirin's effect on cancer incidence was not very conclusive. And let me take you through that information and why that information actually is providing, I think, greater impetus for us to think about a molecular and more personalized approach to prevention than we had in the past. So much of the interest or much of the change in those guidelines emanated from data that emerged from the Esprit Study, which was a large clinical trial of 19,000 older adults. These are individuals over the age of 70 that were treated with aspirin beginning at the age of 70. Most of these people, about 85% of the cohort, had never been aspirin users prior to age 70. And they were treated in a randomized fashion to aspirin or placebo for 4.7 years, so a relatively short amount of follow-up. And there was no difference in the primary outcome, which was disability and dementia-free survival. But what was surprising was they found an actual increase in cancer-related mortality with a hazard ratio of 1.31, which is a surprising contrast to all of the prior clinical trials, which had suggested that aspirin would be associated with a reduction in risk of colorectal cancer. So why would this be? Why is it that potentially this trial showed a different result compared to the many other trials prior to this that showed a decrease in risk? And why is this potentially a indicator that we need to be more thoughtful about who we treat with aspirin, that there is no one-size-fits-all approach to aspirin for cancer prevention? So we wanted to ask the question, well, you have this, very surprising and intriguing finding where aspirin increases cancer-related mortality. What's the effect on incident cancer? So I became involved with the Esprit Study in the last few years to help work on this question. So we looked at trial data to understand, does aspirin associate with a lower incidence of cancer and not just cancer death? Remember, the primary study looked only at cancer death. We asked the question, is aspirin randomization associated with incident cancer? And we actually found no difference. So if you look at the association of aspirin randomization with cancer risk, there was no increase in risk of an incident cancer. In addition, there was no increase in risk of solid cancer and no increase in risk of cancers according to adenocarcinoma or non-adenocarcinoma. However, there was this increase in risk of stage 4 cancer with a relative hazard ratio of 1.22. And that might explain, obviously, why there's an increase in cancer deaths. But it's still quite puzzling as to why you would expect to see an increase in cancer deaths after 4 years of treatment, but no increase in cancer incidence. So this raised the question, is there something peculiar about this Esprit cohort that sets it apart from other prior randomized studies? And in particular, is it the fact that these were people who started using aspirin very late in life at a point in time where maybe aspirin may not make a major difference with respect to cancer prevention, and maybe it was too late to actually sort of reverse the effects of aspirin, or sort of reverse the effects of aging on cancer risk? And also, is it possible that the effect of aspirin may be detrimental at older ages? So we wanted to explore this in a separate cohort. So this is going back to, again, why it's so important to also think about looking at cohorts where there's been a large body of aspirin data collected over long-term follow-up, because it gives us the unique ability to be able to look at the use of aspirin across the life course. And a clinical trial like Esprit is limited in basically only being able to look specifically at the use of aspirin in a very narrowly defined window of time. In other words, in Esprit, they looked at aspirin only after the age of 70 and only for 4.7 years of use. In the Nurses' Health Study, Health Professionals Follow-Up Study, we had the benefit of over 30 years of aspirin data and actually had collected information on whether people stopped or started using aspirin over their life course. And we found that actually regular aspirin use after the age of 70, in contrast to Esprit, was associated with about a 20% reduction in risk of colorectal cancer. So a different result than Esprit. But why is that result different? Well, it could be because a large proportion of these people that were regular users of aspirin after the age of 70 were also people who started using aspirin before the age of 70. So if you actually stratify the cohort according to whether they had used aspirin before the age of 70, you actually did see substantial differences in risk. Individuals that had been using aspirin before the age of 70 had about a 20% reduction in risk of colorectal cancer. But if they were not regular users before 70, in other words, they were new users of aspirin after age 70, there was no appreciable reduction in risk. And I think this mimics what we see in the Esprit cohort. Again, in a new group of aspirin initiators after the age of 70, you may not see much cancer benefit. And that could be because of biological differences or the fact that after the age of 70, in the sort of pathways that associate with development of cancer may already be underway. In other words, the horse may be out of the barn, it may be too late to actually impede or reverse some of those processes. So I think this was valuable complementary data to what was published in the Esprit cohort. And I just want to recognize Chung Guo Guo, who was a medical student working in our group at the time, an MD PhD student, who really led this analysis. So this has raised the biological question that's intriguing, is there a potential that there is a different effect of aspirin according to the time of life at which you use it? As you might imagine, cancer in colorectal cancer could be different at earlier ages. We know that mutational profiles, for example, of earlier onset cancers may be different than older onset cancers. Some of the pathways that potentially cause cancers to develop at older ages may also be different. It may be, for example, in older age that more epigenetic alterations or other sort of pathways may be operational, and these may be relatively less sensitive to aspirin. So you can imagine there is potentially a window in which aspirin is effective in younger life, but then in later life, either that window is closed and aspirin may not be effective, or it's even possible that aspirin could be detrimental and cause tumor growth and metastasis, which may be why you see a detrimental effect in older adults with stage 4 disease in the Esprit cohort. So this has led us to pursue this as a biological study and a biological question. And we actually have been focused in on several different areas, but one really promising area is to understand, does the cell have origin for tumorigenesis? And maybe therefore the target for aspirin chemoprevention change with age? For those of you with a background in basic science, you know that in, for example, mouse models and also human studies, it's been pretty clear that the cell of origin for colon tumors, at least in younger people, are what we call LGR5 positive colon cancer stem cells. And these may be stem cells that are relatively sensitive to the effect of aspirin. But our colleagues, Omar Yilmaz at the MIT Koch Institute and Thad Stappenbeck at Cleveland Clinic, have shown that actually the cell of origin for cancers that develop in aged mice or older mice may be different, and it may not be the LGR5 positive stem cell, but could be a progenitor cell. And those progenitor cells may in turn be less sensitive to the effects of aspirin. And this is something we're exploring in an extension of our clinical trial called Esprit XT, which is enrolling older adults on an aspirin protocol. So I also want to sort of go into, in just a very brief amount of time, the idea that maybe aspirin has effects beyond the colon. I think the most compelling data have been for the prevention of colorectal cancer, but there are also emerging data that aspirin may have an effect in other cancer types, including liver cancer. And liver cancer is a particularly high unmet need, given that there really are no good preventive options for liver cancer. So this was a study led by Tracy Simon, who was a GI fellow at the time and is now a junior faculty member in hepatology at MGH. And she showed in the Nurses' Health Study that regular aspirin users had about a 50% reduction in risk of hepatocellular cancer overall, but also that risk was also seen in both men and women. And many of the hepatocellular cancers in the Nurses' Health Study are likely to be related to non-alcoholic fatty liver disease. So it suggests that a leading cause of cirrhosis and HCC could be preventable with aspirin. But she wasn't content to sort of rest there. She was interested in knowing, well, is there potentially an effect of aspirin on other types of liver cancer and other types of liver-related comorbidity that results from the other major form of liver disease, which is viral hepatitis. So in collaboration with Jonas Johansson at the Karolinska Institute, she conducted this study using data from the Swedish registry cohorts, where they have very highly precise data on pharmacological prescriptions and also on cancer outcomes. And she found among a cohort of individuals that had viral hepatitis, individuals that were taking aspirin or initiated aspirin actually had a lower risk of developing HCC or dying from liver-related causes compared to those that were not using aspirin. So in the two major types of liver disease, namely fatty liver and also viral hepatitis, aspirin may play an important role in terms of prevention. So I do want to leave you with, I think, the sort of future of cancer prevention. I think we increasingly are understanding that in cancer prevention, the idea is that we take relatively healthy people and tilt the balance toward an anti-cancer milieu to try to get their body to a state where it's less likely that they will develop a cancer. And we had until now been very focused on kind of one-size-fits-all approaches, where we were thinking, well, maybe we could recommend something like aspirin to the broad population and lead to anti-cancer benefits across different individuals. But it's pretty clear that we need to be more molecularly specific. We know there are various factors that tend to actually promote tumors. We know family history of cancer, older age, obesity, for example, are pro-tumorigenic. And it's possible that aspirin could actually shift that balance to a more anti-cancer effect if these risk factors are in play. On the other hand, there's all these other factors to consider. There's also the idea that when you actually start using aspirin could be important. It may be that you need to use aspirin in an earlier point in your lifespan when tumors first initiate. There's also questions about optimizing that balance with respect to dose and duration, and in terms of being able to balance not only efficacy, but also toxicity. And also there are various other components of the pathway. the microbiome, also prostaglandin pathway components. I haven't had a chance, but there's also been an interest in our group in exploring the proteome or the metabolome as also potential factors that may change the balance between an anti-cancer effect or a pro-tumorigenic effect. And I think this striking of the balance for an individual patient is going to be the key for being molecularly selective in the future for deciding who we want to treat with aspirin. So that in the future, we won't be reliant on sort of one-size-fits-all strategies, but use aspirin in individuals that are most likely to benefit and least likely to be harmed. And I think that's really where the future of chemo prevention will be. And I think that's hopefully something that we could think about as an adjunct to those strategies we know help in terms of prevention, specifically colorectal cancer screening. So in summary, I hope today what I've been able to show you is that the mechanisms by which aspirin prevent cancer could be risk stratified for chemo prevention. In our clinical trial of aspirin, we've actually shown that aspirin reduces urinary prostaglandin, which is a potential biomarker for the development of adenoma and cancer. And we are able to actually show that even short-term aspirin use could reduce it to levels where there has been shown to be a reduction in risk of recurrent adenoma or colorectal cancer. In addition, other molecular biomarkers could be important for precision prevention and patient risk stratification. There is, however, concerns about broad-based recommendations related to aspirin. In particular, the Esprit randomized trial showed this unexpected increase in cancer mortality, but not cancer incidence in older adults after relatively short-term follow-up, which raises the question of whether there is a differential effect depending on the timing of initiation and host age, and of course, duration. Again, Esprit was a short-term study, so with longer duration of follow-up, it is conceivable that aspirin could show a benefit as it has with prior clinical trials. And then finally, I hope you will understand that there is promising data suggests that there is a benefit for aspirin for cancers, in particular liver cancer. So I do want to recognize all the folks who've made this work possible, including folks in our clinical and translational epidemiology unit that led a lot of the data, the studies that produced the data that I presented today, including David Drew, Chung-Guo Guo, and Tracy Simon, and also many collaborators for whom we are indebted to our collaboration, including Curtis Huttenhauer, Wendy Garrett on the microbiome studies, Sandy Markowitz on the PGM data, and also Shuji Ogino, who's been our collaborator on the pathology specimens, including the assay for COX-2. In addition, Thad Stappenbeck and Omo Yilmaz on the work we've been interested in pursuing on differences in colon cancer stem cells as an explanation for differential effects of aspirin by aging. And of course, we want to recognize the invaluable contributions of our study participants, both in our clinical trials and also in our population-based cohorts. And with that, again, I want to thank you for your attention. I know there is certainly a lot going on in your hospital, as with all hospitals across the US. And so I recognize that this has been a stressful period, but it's always great to take some time to connect with colleagues, also share some science. And so it's been a lot of fun being able to visit with all of you, even though it has been virtual. And I look forward to interacting with you, and I'm now open for any questions you might have about this work or anything else that you'd like to discuss. Thank you very much.
Dr. Chan, I want to thank you so much for an excellent and interesting talk. I'll open the floor up now for Q&A, and please pose any questions in the chat, Dr. Chan. We have a couple we can start with here from the presentation. Firstly, can you comment on the indication bias in using observational data to associate aspirin use in colorectal cancer? That could be changed based on the reason people are taking aspirin and those reasons driving colorectal cancer risk.
So it's a great question. Any pharmacoepidemiological study obviously should be concerned about bias by indication. Certainly, the reason for why people use drugs may be the real reason for why there's an association with a given cancer. We think that's less of an issue for the observational data for aspirin for a few reasons. Number one, it's not just observational data that's really shown this association. As I mentioned, there are clinical trials Both the primary trials that have been done that show reduction in risk of adenomas really, I think, has cemented the idea that there's an anti-cancer effect of aspirin. In addition, there are clinical trials of aspirin, including the Women's Health Study, the CAP2 study, the various cardiovascular studies where randomized aspirin use and being randomized to aspirin was linked to lower risk of cancer. So there should be no issue with indication bias in those types of studies. In addition, with indication bias, you would imagine that the reason for why people take aspirin would largely be due to treating aches and pains or maybe cardiovascular disease prevention. And in general, those shouldn't be linked so much with cancer. There are some overlapping risk factors between CVD and cancer, but CVD itself is not going to be a strong risk factor for cancer. And in some situations, it could be a competing risk situation. In addition, we do think that, for a lot of people who were taking aspirin earlier in some of these cohorts where some of this data emerged from cohorts followed in the 1980s and 1970s, CVD prevention was not a principal reason for aspirin use. It was actually pain relief, et cetera. And so there's not a strong relationship between analgesia and the use of analgesia with cancer. So indication bias is probably not enough to explain those findings. And then lastly, there are studies, including our studies in the Nurses Health Study, where we did collect indication of use of these drugs. And if you actually look at the indication of use, there wasn't any difference in the association of aspirin with cancer risk.
I see. Excellent. Next question is, are there any adaptive benefits to patients who have baseline higher levels of prostaglandin metabolites in the urine that would be negated by putting them on aspirin?
That's a great question. So, prostaglandins are pro-cancer causing. So in that sense, they're detrimental, but prostaglandins may actually have good effects. And in particular, for example, in the gastrointestinal mucosa, prostaglandins are responsible for healing of mucosal injury. And that's obviously why aspirin may cause injury to the mucosa and ulcers. So you could imagine that, a deficit in prostaglandins could be something that potentially causes a deficiency in the ability to wound heal or to heal injury. So I think what's going to need to be thought of is, probably attaining some level of balance. And there's probably some level of prostaglandin tone, which is optimal to sort of maintain healthy mucosa and wound healing, but not let it get to the levels at which it potentially could be detrimental in causing cancer, but not suppress it to the point where you start to have an inability to heal injury. So I think there's going to probably be some careful balance. And I think our urinary prostaglandin metabolite studies suggest that there's probably a threshold by which you don't want to exceed, where that could be linked to higher cancer risk. But if you sort of stay below that threshold, it's probably the appropriate balance.
The next question here is it possible that the aging effect you spoke about with liver cancer is a survivor effect, as in the cohort who would have died from cardiovascular disease are protected by aspirin and that therefore live longer enough to develop liver cancer?
Yes, that's also a great question. So in the analyses we've done, we did carefully use approaches which can consider competing risks. So competing risks obviously is always something that you need to really be concerned about with long-term studies like ours. In addition, we also looked more broadly, not just even at HCC specifically, but sort of overall liver-related mortality, and found that there was a benefit with respect to liver-related mortality. So some of the pathways that seem to be preventing cirrhosis or preventing liver disease from progressing seem to be inhibited by aspirin. So it may be an effect not only on HCC development, but also progression of liver disease, which is also very intriguing. Something that Tracy Simon is pursuing in some of her studies, where she's actually looking at associations of aspirin with fatty liver and fibrosis and some intermediate pathways related to that.
Great, excellent. We have time for one more of these questions here. So I'll choose the last one that came through. Do prostaglandins contribute to the link between ulcerative colitis and colon cancer? And should prophylactic aspirin be considered for UC patients?
Great question. So the molecular mechanisms that underpin the development of cancer and IBD probably are different. I think there's a pretty clear progression of molecular changes in IBD-related dysplasia that are probably different than non-IBD-related cancer. So it's possible that you may see an anti-cancer benefit for non-IBD cancer, but no anti-cancer benefit for IBD cancer. That being said, no one's actually looked at that in a rigorous way. There's been sort of lingering concern about NSAIDs and aspirin in IBD patients and causing flares of colitis. Some of our data suggests that that's probably not probably a major issue with aspirin and maybe more of an issue with NSAIDs. So there is that opening for aspirin for patients with IBD cancer prevention that still is remains to be explored, and I think it's certainly possible to consider thinking about that, a study in which we think about using aspirin as a preventive agent in IBD. Of course, the limitation or the difficulty and challenge in that kind of study is that IBD is a risk factor for colon cancer, but IBD-related cancer is still a relatively rare outcome. So you really need a very large study and a large clinical trial to be able to be sufficiently powered to see a definitive result. So it may be difficult to get the standard of data we might want to be able to answer that question.
Well, it's right at 1 o'clock, so we're out of time, but I want to thank you again for that excellent talk. And I want everyone to have a good weekend, and we'll see you all next week. Take care.
Thanks very much. Thank you very much.
Bye.